and welcome to the Asian Geriatric Oncology Society webinar series, the 10th webinar in our series. We are taking up a very important topic in this particular webinar, and that is frailty in geriatric oncology. And I have the honor of actually having uh, one of my mentors who has actually done literally hand holding, if I have to say, in teaching me geriatrics from day one. So that is Dr. Priya Vijayakumar, who is the current HOD of geriatric medicine and Amrita Institute of Medical Sciences in Kochi, and I being her first MD geriatric student. I'm not sure whether she's proud of it or she's irritated about it, but I am. That's the fact that I am. So, and I'm sure that she's going to shed a lot of important light as far as frailty is concerned, which is, I think, a term which we have heard quite a bit in all aspects of care as far as older adults are concerned. But it is very, very important in geriatric oncology. And let us see how ma'am can shed better light on it. Thank you, Priya ma'am, to be on this panel. Thanks a lot.
Good evening. Good evening, Prem. I'm really proud of you, Prem. No doubt.
Thank you. Anyways, I was just trying to pull your leg. So please do go ahead.
Oh, thank you. My slides. Okay. Good evening. My topic for today's presentation is frailty and chronic diseases. So I'm covering the frailty as a whole. What is frailty, and how will you identify frailty, and what are the points to diagnose frailty, and how can you manage frailty? So this is in general about frailty, and maybe because when you hear the term frailty, the first thing which comes to our mind is a thin built, old, very tired, frail, very tired individual. But that is not true with frailty, because even young persons or even obese persons can be frail. So let's see what is frailty. So frailty means it goes beyond the physiological process of organism aging. And it can happen in young patients or it can happen in obese patients. And it actually hit the physiological reserve of our system. Next slide. Next slide. So what is frailty? It's a physiological syndrome characterized by reduction in reserve. That means every organ system in our body has a physiological reserve. And this reserve is needed for an individual to fight against a disease or a chronic condition. So what happens in frailty is that there's a reduction in reserve and resistance to stressors resulting. And how does this happen? This is due to the reduced performance of different physiological systems, which in turn lead to susceptibility to adverse consequences. So the points which I've mentioned in red are the points to be highlighted. So there is a reduction in reserves and resistance to stressors, and due to the reduced performance of different physiological systems, which in turn leads to susceptibility to adverse consequences. So this is the definition put forward by the Fried et al. In 2001. Next slide, please. Now, there are two major groups of defining frailty. One is a phenotype definition of weakness, and second one is the accumulation of deficits. Next slide. So this is the diagram which shows the two definitions. So if you see in the first, there is reduced physical activity, reduced muscle strength, reduced energy level, reduced walking speed, and weight loss. So these 5 components of frailty. In the second one, if you see, it's a social vulnerability, multiple medical conditions, there is functional decline, psychosocial aspects like depression or poor cognition, poor nutrition, all this leading to frailty. So if you put both definitions together, final thing is that there is diminution in reserve, the body is becoming weak, there is dependency, disability, and leading to death. Next slide. So this is the Freud's criteria. So there are 5 points. That is shrinking of the body, exhaustion, weakness, slowness, and low physical activity. If you have 3 or more of this, then the person is termed to be frail. And if it is less than 3, then it is a pre-frail condition. So these are 5 criteria for frail's 5 criteria for diagnosing the frailty. Next slide. Next slide. Okay, so this is the this diagram shows how frailty acts on an individual. So there is, from anywhere, any stress happening to the body, this is the cycle which is going to happen. So the individual will be having weight loss leading to sarcopenia, because sarcopenia is the main center of frailty. And sarcopenia, there is reduced metabolic rate, reduced total energy expenditure, reduced activity, reduced walking speed, reduced strength. Again, reduced walking speed means disability and dependency, and reduced strength means again going either to sarcopenia or to frailty and reduced strength going in for impaired balance, falls and injury, immobilization, disability, dependency. So wherever a stress happened in this cycle, this is the final point, that is the reduced activity, reduced walking speed, reduced strength, impaired balance, fall and injury, immobilization, disability, and dependency. So this is the cycle which is happening in an individual. Next slide. This again shows the graphical representation. So if you see step by step, the graph is coming down. So initially robustness, then again, if you have a stressor, you will have an early recovery. If you are pre-fail, stressor is happening, but the recovery is slow because it's taking some time for the person to recover to the normal state. If you're frail, the stressor is happening. If you can see the line is going flat. That means more time is taking, and there is no recovery in frailty. It is dependency, disability leading to death. Next slide. And frailty usually is a final result of interaction of changes in several systems, resulting in a global process in which sarcopenia is considered a major component. So that is the key word, where whatever stress happening to the body, if a person is frail or reduced physiological reserve, then sarcopenia is the main component. Next slide. Okay, so there's a genetic factors, environmental factors leading to cumulative molecular and cellular damage, leading to reduced physiological reserve. That means reduced physiological reserve in all of our system. Let it be neurology, endocrine, immune, skeletal muscle, cerebral, cardiovascular, respiratory, renal. Next slide. And then reduce physical activity. Then along with that, nutritional factors acting. That means reduced protein, reduced carbohydrate. Then again, there is especially reduced protein. There is again sarcopenia. Person is becoming frail. A stress is happening. Then falls, delirium, fluctuating disability, dependency, leading to either increased care needs, admission to hospital, or admission to long-term care, leading to death. So this is the cycle of frailty. Next. And the importance is that anywhere in this graph, that means in the physical activity or nutritional factors, you can intervene. So physical activity means increase of physical activity through various exercises and address the nutrition with a diet. So to some extent, the rest of the cycle, that is dependency, disability, admissions, can be reverted or reversible to some extent, but you can never bring back a frail person to the normal person back. But still, the number of admissions and the recovery can be attained to some extent if you address the physical activity and the nutritional factors. Now, aging and frailty. Next. So there is increase as we age, there is increased vulnerability to advanced and persistent loss of function and accumulation of pathological processes. Next slide. And the 3 main mechanisms which is acting in the in frailty are apoptosis, senescence, and inflammation. So these are the three mechanisms by which a body is changing into the process of frailty. Next slide. Homeostatic mechanisms affect change through these responses, thus they are likely candidates for pathways that contribute to the failure of homeodynamic seen in frailty. Dysregulation of apoptosis may contribute to frailty traits of sarcopenia and weakness, and cellular senescence, that is secreting pro-inflammatory cytokines, may contribute to the dysregulated inflammatory state seen in frailty. So these are the three major mechanisms, that is apoptosis, inflammation, and change in the physical and change in the various mechanisms. Next slide. Higher rates of inflammatory markers in blood is associated with greater loss of muscle mass and muscle strength, leading to accelerated loss of mobility, low limb performance, and hence physical activity and depression, which all defines the characteristic of frailty. So this is what the inflammatory markers. So that is said to play a major role in reducing the muscle mass and muscle strength, leading to sarcopenia, again, which is a core component of frailty. And interleukin-6 is supposed to be the inflammatory marker, which plays a major role in making the body or making the individual prone to sarcopenia. Next slide. And there's an article which shows the markers of inflammation and association with muscle strength and muscle mass. Next slide. So in any definition, there are changes in 4 main processes. That is change in the body composition, homeostatic dysregulation, there is energy failure, and there is neurodegeneration. Next slide. So this slide shows the various changes happening in each of the heading in the body composition, hormonal dysregulation, energetic failure, and neurodegeneration. Next slide. Next slide. How does a patient of frailty present? So the patient can present you with extreme fatigue or unintentional weight loss, frequent infections, balance and gait impairment. Patient could be delirious, feeling very low, dull, forgetful, and fluctuating disability. Next slide. And this is a central phenotypic manifestation of frailty sarcopenia, and these are the characteristics by which the sarcopenia happens. I think this slide should have gone to the other aspect. Next slide. How to diagnose frailty. Next slide. So criteria for defining frailty by the British Geriatric Society guideline, a gait speed of less than 0.8 meter per second, timed, that is stuck test more than 10 seconds, a score of 3 or more on the Prisma 7 questionnaire can indicate frailty. This is one way of diagnosing frailty. Next slide. And this is the Prisma 7 questionnaire, because these are the various scales by which the frailty can be diagnosed. That is, one is Prisma 7 questionnaire. Next slide. This scale is the one which is used by the British Geriatric Society. So another scale is Dr. Navneet's criteria, Dr. Presum's criteria. Next slide. Next slide. Clinical frailty scale. So this is one of the easiest scale which can be used for diagnosing frailty, because there are pictures in the scale. So any medical person, need not be a doctor, a nurse or a medical social worker can pick up, or an ASHA worker, community health worker, anybody can pick up frailty in an elder individual, because there's picture representation. Next slide. And clinical frailty scale is a quick and simple tool for describing various degrees of frailty. If we get a score of 1 to 3 in the clinical frailty scale, they are fit, active, and independent. Clinical frailty score of 4 to 6, they are vulnerable. And less than 6% have hospital admission. Next slide. Clinical frailty score of 7, severely frail and completely dependent, and aggregated risk of death of 11% during hospital admission. Clinical frailty score of 8, very severely frail, completely dependent, and aggregated risk of death is almost 24% following a hospital admission. Clinical frailty score of 9, terminally ill with a life expectancy of less than 6 months. So this score can help in identification and risk stratification, and this is a very easily applied tool for diagnosing frailty. Next slide. Next slide. So a systematic review incorporating 31 studies of frailty in persons 65 years or older found a prevalence of 4% to 17% of physical frailty with a higher prevalence when psychosocial frailty was also included. Women, 9.6%, were almost twice as likely as men to be frail, and the prevalence of frailty is markedly increased in persons older than 80. So these are some of the epidemiological evidences towards frailty. Next slide. And factors associated with increased prevalence of frailty: older the age, low education level, current smoker, current use of postmenopausal hormone therapy, unmarried status, depression, intellectual disability. So these are the few of the factors associated with increased prevalence. This, we got it from different studies. Next slide. So this is etiology and risk factors like aging, genetics, lifestyle, disease, environment, and the potential mechanisms. We have gone through this earlier, that is chronic inflammation and chronic inflammation. That is under chronic inflammation, there is the cytokines, immune cells, and the various immune and inflammatory pathway activation, leading to musculoskeletal and leading to the, or these chronic inflammation is going to affect the various systems of the body like musculoskeletal, endocrine, cardiovascular, hematological, brain, etc., leading to weakness, weight loss, exhaustion, low activity, and slowed performance, which in turn leads to various health outcomes like falls, disability, dependency, and death. So this is how the frailty happens in an elder individual. Next slide. Next slide. So this is again a principle of frailty and chronic disease. So what happens is that if you see in the older adult age, where there is where the patient has comorbidities like congestive heart failure, hyperthyroidism, and sarcopenia. So these three, they have the converging effect on the clinical phenotype, that is effect 1, effect 2, and effect 3. If you see an older adult B, where depression is a major issue, if you see the arrows, they are diverging. So the depression as a disease process can make the person weak, or can make the person slow, or can make the patient fatigued, or else these three can happen in one individual. So it can, the frailty in an older individual with the comorbid conditions, it can have either a converging effect or a diverging effect. Next slide. And it has been theorized that multimorbidity entails clinically overt diseases, and distinct from multimorbidity, frailty is an aggregate of subclinical losses of reserve. So whatever the comorbid conditions the patient has, whichever system is getting involved, the underlying process is that the subclinical loss of reserve. Next slide. Multidimensionality or involvement of several physiological subsystems is a core characteristic of frailty. Next slide. Next slide. Okay. Having several physiological impairment, what does this lead to? There is reduced physiological reserve or the physiological inefficiencies. And this an individual with low physiological reserve, often in the presence of multiple diseases, may perform less external work to avoid spending more out of a smaller pool of internal resources. That means these already there's a physiological, that's it, reduced physiological reserve. So these inefficiencies may become manifest as frailty, often in the presence of disease. So when a person has multiple comorbid condition, this low physiological reserve will manifest itself as frailty. And as a consequence, the frail older adults may perform less external work to avoid spending more out of a smaller pool of internal resources. So in other words, the individual is going to become less active, more dependent, and slowly, gradually declining in their physical strength. Next slide. And the motivation for understanding punished inefficiency is to reverse frailty, possibly by improving energy efficiency in older individuals through appropriate therapies that augment the compensatory mechanisms. So adapt to the mechanisms which will help to augment the compensatory strategies. So that may help your frail individual to some extent. Next slide. And these are some of the diseases which are independently associated with frailty. Next slide. So these are again a list of diseases which can be associated with frailty, or these diseases can be there if these diseases in combination is present in a frail individual, then the other cycle of physical dependency and for leading to death will be quicker. Next. The mean number of chronic diseases experienced by a frail older adults was roughly 2.1, compared with 1.4 among non-frail older adults. So this is another point. A frail individual, the number of comorbid conditions in a frail individual can be more, or vice versa, a frail individual can acquire a number of diseases than a non-frail individual. So either way, this can happen. And then what happens is that once the frailty is there, the multiple comorbid conditions is there, then the nutrition is affected, their physical activity is reduced. If you are not going to intervene at that point, the graph will be going on in a very downward trend. And these are some of the associations with chronic diseases, that is frailty and hypertension. I think you can skip these slides. Next slide. All this again. And next slide. So in whichever chronic diseases is there, if you intervene address the chronic diseases properly, the frailty can be addressed by increasing the physical activity or advising the individual regarding the exercises and advising the diet. To some extent, you can help your frail patients. So next slide. Next slide. Okay. Next slide. The study showed that pre-frail and frail older adults had higher arterial stiffness. This is again regarding with the frailty and cardiovascular disease. This is a mechanism by which frailty can lead to cardiovascular disease. Next slide. You can skip these few slides, Sophia. Next slide. This is in relation with the cardiovascular system. Again, this is with the CKD. You can skip this. Skip this. Skip. Skip this. Coming to the management of frailty. Next slide. So all persons. Next slide. Previous slide, Sophia. Okay. All persons more than 70 years and adults with chronic diseases or weight loss exceeding 5% over a year be screened for frailty using available screening tools. So this you have to remember. If any persons above the age of 70 with chronic disease with multiple comorbid conditions with unintentional weight loss should be screened for frailty. Next. And how will you investigate them? With the routine blood investigations, liver function test including the albumin, then vitamin B12, vitamin D, thyroid stimulating hormone. Next. And 4 possible treatments that appear to have some efficacy in the treatment of frailty are: one is exercise, calorie and protein support, vitamin D, if low, needs to be supplemented, and polypharmacy has to be addressed. Next slide. So this is the Asian Pacific Clinical Practice Guideline for the management of frailty. So these are the recommendations what they put forward: strong recommendations, conditional recommendations, and no recommendation. So this is the Asian Pacific Clinical Practice Guideline. Next slide. This slide is important because you have few reversible conditions which can be reversed and the effect of frailty can be reduced. So like sleep apnea, depression, anemia, hypertension, hypothyroidism, B12 deficiency, because all this can be treated. So if your frail individual has these conditions, you treat these conditions, then the individual will be little more better than what the initial status is. And of course, exercise very much. Next slide. So again, exercise for improving the physical activity of individual, and what exercise to recommend is very much individualized, because considering the age of the person, the number of comorbid conditions, and the medications what the person is on, and based on the biochemical test reports, you will have to advise the patients regarding exercise. And maybe always start low and go slow, gradually increase the exercise level. And it's always better to take the help of a physiotherapist with the advice of the treating physician. Next. And there is no hardcore criteria that they should be sticking on to this exercise. Whichever exercise the individual is fit, you can continue that particular exercise. Then next slide. Coming to, again, this is another area where you can intervene, that is the diet of the individual, because muscle mass, reduction in the muscle mass and muscle strength is directly proportional to the protein loss. So the protein loss can be supplemented with the help of the diet. In diet, based on you calculate the BMI and see how much calorie the individual needs. And in the calorie, you divide as this much percentage of protein, this much percentage of fat, and this much percentage of carbohydrate. Of course, as we all know, protein leads the list, and minimum of 1 gram per kg body weight, but always depending on the clinical comorbidities what the individual has. You can step up to 1.5 gram per kg body weight wherever needed. You can use protein supplements, again based on the comorbid conditions. Next, about 20% of the total calories should be supplemented by the carbohydrates, and then 10% by the fat. And it's very, very important to see that it's not the quantity what matters, it's the quality of the food that matters. So if an individual is on a feeding tube, again, you will have to calculate the calories and make sure that the person gets sufficient protein and sufficient carbohydrate and sufficient fat. So whichever mode the person is taking food, you have to see the quality of the food, and then try to get the needed calorie for the individual. Next slide. Next slide. Again, so the previous slide is about the polypharmacy. So polypharmacy, more than 5, as per the Bayes criteria, if an individual has more than 5 drugs, the the person is termed to have polypharmacy. But then if you see an elder with a number of comorbid conditions, definitely the individual will be having more than 5 groups of drugs. So anyway, stick on to the best criteria and start and stop criteria wherever possible. And adding any drug, start in the low dose and gradually step it up. With each visit, you will have to ask your patients to bring the drugs and go through the drugs and optimize the medications. Otherwise, what happens is that some of the drugs which has been started by some physician, even after the time of stopping, but they'll be still continuing it. So it's very important to see the drugs with each visit and optimize the medication. And as we have told, during the screening, we'll be screening some of the vitamins like vitamin D, vitamin B12, supplement if low. And most of the time, again, if you see, the person will be having a prescription of Neurobion, prescription of Renov or Renov Plus. So again, as we know, methylcobalamin is all needed in very small quantities. So if you want to give your elders these vitamins, use judiciously. If you are in doubt, check the vitamin B12 level. And if it is more, discontinue the drug. Again, vitamin D, because in tropical countries like us, we usually should not be getting vitamin D, but now very frequent. Vitamin D deficiency is very frequent. And it's always better to check the vitamin D and then supplement it. And because we should be a little careful about the hypervitaminosis conditions too. Next. So suggested dosage is between 800 to 1000 international units of vitamin D daily. Next. Take home message. Frailty in older adults is considered to be the hallmark geriatric syndrome. That is a forerunner to other geriatric syndromes, including frequent falls, fractures, delirium, cognitive impairment, and incontinence. And frailty has converging and diverging effects with chronic disease. Hence, identifying frailty and its phenotypes are important so as to capture the patient in appropriate time to reverse disability and thereby providing healthy age. Thank you.
Thank you, ma'am. So I think that was quite an exhaustive and descriptive lowdown on frailty. Of course, as the word suggests itself, there's plenty in the word, but frailty has actually many layers to it, and we obviously need to understand that. So now, of course, we'll go into the panel discussion. So let me just introduce our chairperson, that is Dr. Purvish Parikh, sir. So he is our chairperson, and the moderator today is Dr. Amish Vora. He gives plenty of hope to people in Delhi. So he's a medical oncologist from Delhi. So, sir, over to Amish, sir. If you could just introduce the the panelists, and then go ahead. Thank you. So you're on mute, sir. Mute.
Yeah. Am I audible now?
Yes, sir.
Okay. So we have Dr. Priya ma'am, who just delivered a very comprehensive lecture. And we have Dr. Arun Warrior here. Can I request Dr. Prem also to be there as one of the panelists, if that is okay with Dr. Prem?
Yeah, sure.
Fine. Perfect. Can I share my slides? Because when I write the chair, it comes someone else is sharing. Yeah. Okay. My slide is visible?
Yes, sir.
Okay, perfect. Thank you. Thank you, Dr. Prem, as always, for giving opportunities, and that also helps me revise a little bit of geriatric oncology, which I know. So we have talked about the panelists. So I'll go to the case discussion. Patient is an 89-year-old female, came walking to my OPD without any support. She was diagnosed with squamous cell carcinoma. The squamous cell carcinoma is extensive, right from the lip, buccal mucosa, hard palate. Initially, the extensive leukoplakia in both the sides and squamous cell carcinoma both are seen. She carries the weight of 38 kg. There are no comorbidities, no diabetes, hypertension, cardiac, CKD, anything. She says that she keeps having recurrent hypoglycemia. Symptomatic hypoglycemia is in terms of giddiness, not more than that. And the lowest reported value of sugar is 78. When I asked her, have you lost weight? She says she was always thin and she might have lost 3-4 kg because of she's not able to eat. She stays alone, 25 kilometers away from Hope, with 2 caretakers. And there is one relative who is nearby, 1 kilometer away from where she stays. She has 2 daughters who stay abroad, one in Dubai, one in London, and both of them are on phone touch with her, and they were wanting to be in touch with me. Her 2D echo is normal. Creat clearance by Cockcroft-Gault formula, although it's not an age-appropriate formula, is 65 ml per minute. I didn't do DTPA because creat was also normal. Her pulmonary function test was okay according to pulmonologist. There were no geriatric syndromes. There was no dementia at all. There was no weight loss, no memory loss. She does her own banking without any help from any of the daughters. And she remembers all her account numbers. If you ask her, she says, yes, I remember all that. So let me start with Dr. Arun Warrior, sir. Dr. Arun, what would be your next step?
So I think you have a very exceptional patient out here. So 89 years, perfectly fit. So we see such patients, not very uncommon if you ask me. So thing is that she's well-read and very connected. Daughters also are there. So yeah, definitely I'm not, it's a localized cancer. From a cancer perspective, few things are that these things can remain localized. And we know they can be locally increased also. So definitely I feel surgery is not possible at this age group. Radiation also, they are quite skeptical about that. And now we have this immunotherapy, which we know has got a role in head and neck cancers. So chemo first, followed by immuno for normal people. But for 89 years, I'm not very skeptical about giving chemo for them. So finally, I may end up, and immunotherapy, definitely some people get very dramatic response also. So I won't say no treatment to her because she's otherwise fine. So I will think about immunotherapy. That's what, if you ask me, that is what a treatment perspective I will take.
So you will think about immunotherapy. So Dr. Prem, Dr. Arun has decided about immunotherapy and sent the patient to you for your assessment. Based on these, would you do a geriatric assessment or the frailty index calculator, what we see from Canada, Germany, and other European countries?
Yeah, I would definitely do a geriatric assessment purely because, yes, maybe she does not present with a syndrome per se, but that is the key to any assessment of an older adult, that we actually try to detect something which might or might not be bothering them, but it is actually something which is hidden. So, and especially a lot of times frailty can be hidden because from the person's perspective, the person might feel that they are doing pretty well, but she obviously is not. She's not very, as far as her BMI is concerned, it's not that great. So that is something I would want to consider. What was her height? I don't remember.
She was never 41 kg or 42 kg and above, Dr. Prem.
Okay, so
That's
she was
what she
always
told
the
me.
same.
She said she was always like this for last whatever 60, 70 years she remembers.
Okay, and she's on the. Is she? Of course, I would want to know if she's on any medications. Was she on any other medication?
No polypharmacy. No polypharmacy at all.
Okay, and no comorbidities also, I suppose.
No comorbidities.
Okay. I would still want to assess her for frailty and see.
Right. So, Dr. Priya ma'am, since you are a teacher of Dr. Prem, let us see that whether he has passed in this or not. What I say is that in a busy OPD, if a patient comes walking and all the parameters are normal, there is no diabetes, no hypertension, no geriatric syndrome, no polypharmacy, patient does not have any history of fall, patient is not malnourished, there is no sarcopenia visible. Do we spend our time in doing geriatric assessment or the frailty index in this patient? Dr. Priya ma'am.
No, I agree to you, sir, because in a busy OP, because overall, if you see no comorbidities, her weight was always the same and no geriatric syndromes. So as Dr. Arun was saying, directly go on to the lesion, address that, maybe subsequent to that. you can do a frailty index or the comprehensive geriatric assessment and then correct. That's what I feel, because overall
Right.
she's preserved. Well
So,
preserved, actually.
Priya ma'am,
So-
in case if we have time to do geriatric assessment, so first you ma'am and then Prem, what percentage of patients ideally or finally turn out to be frail in spite of all the parameters which are described as normal? Say, for example, I say I'm not that busy, I can do geriatric assessment in all patients.
Yes.
All the parameters are normal, but frailty index is high. What percentage? Percentage, ma'am.
Not very. Usually, I don't do frailty index and OP at all, sir.
You
Because
don't do.
OP setup, it is very difficult to do
I
a
know.
frailty
Do you do
index.
geriatric assessment, ma'am?
Geriatric assessment also mostly in IP patients, not in
Only in
FBCO.
IP patient. Okay.
Yes. And maybe
Dr.
we'll
Prem?
just
Yeah. Dr. Prem?
Yeah, so I usually do the screener. So I do
Ah.
scope C. So scope C, when I do in that, usually there are questions which are reprimanding, especially to nutrition and frailty. So that gives me sort of an indication. So I would say, if you see percentage wise, if I have to say people who are otherwise normal, I think it will be difficult for me to say. But yeah, I mean, I have found out people who look okay, but they have actually been frail on the scale. And then when we have sort of gone low and slow as far as the medication is concerned, they have tolerated it, and then we have actually increased later. So I think that is something which we've done. Of course, the lucky part here is when we do it, we obviously have the oncologist in sync. So it helps. It helps, of course. I mean, in a center like mine, because we have the oncologist and the geriatrician doing it almost simultaneously. Yeah.
Right. I didn't put those papers because I thought that Dr. Prem and Priya ma'am would know about the percentages. But there is 23% difference between the normal appearance of an elderly person and frailty index being high. You know, as ma'am said that 1 to 2 parameters are fit, more than 2 are frail, and then after that is very frail. So 23%, that means 1 in 5 or 1 in 4. So my point is that if we have time, I think especially I'm talking of only cancer and elderly people, because that is what I am. I am not a geriatrician. So this is what, and that's the reason I feel that in spite of patient looking very fine, we should do a frailty index or at least basic screening geriatric assessment in these patients. That is what I came to know. Okay. So this was Dr. Prem. Uh, is frailty age and comorbidity dependent, or is it dynamic on external stressors also? I'll tell you, I am little confused. Priya ma'am said frailty is irreversible. I think, then my entire lecture or entire thought process about frailty stops here. Uh, what I wanted to ask you is that, is frailty dynamic on external stressors? Because the definition of frailty, what I read, was assessment of vulnerability depending on the external stressor points.
Yeah. So as far as there is a term obviously known as homeostasis, which is obviously there. So what happens is, if the equilibrium of the body gets affected due to an external stressor, then in geriatrics that can be very dynamic. So according to me, frailty is quite dynamic, but one has to understand where they were initially. So for example, if they were pre-frail and then they are getting into a frailty, then there is another story. If they are already frail and they get another disease, usually they don't come back to the pre-frail. They actually continue to be more worse. However, it depends on what disease. I'll give you an example. If a person who is already frail gets a UTI, the chances of recovery for them to come onto the baseline is less as compared to a person who was pre-frail. But I believe that depending upon the number of comorbidities, depending upon how the overall profile of the person is, we need to judge frailty to be dynamic. But at the same time, we need to see what is the baseline, because that is the reason I said about I would like to do an assessment before also, just to know the baseline of the patient pre-treatment. Because if post-treatment the person becomes frail, then is it because of the treatment and side effects that the person has actually become frail, or is it because the person was already frail? So that is a doubt which is already lingering. So I always try to do a pre-assessment as well.
Fair enough. Dr. Arun,
Yeah.
in this slide, what I have shown is there were two external. So if you see, assuming that this is one particular patient's journey, resilience or the intrinsic capacity, which is in the green, is good. Suddenly, an external stressor, that is a cancer diagnosis, and the thought of starting immunotherapy, stroke chemotherapy is there. The frailty increases. Then you do something about it, and then again the frailty comes back. But as Dr. Prem said, that it is never to the baseline. So, do you think that this helps you in day-to-day practice in oncology when you decide about the patient's treatment?
Definitely yes, because in an 89-year-old and all, the main issue is that whether to treat them or not, because none of the trials included such very elderly patients. So that's the first
Assuming
thing we
Dr.
tell
Arun, it is
them. Yeah.
79 years of age. Let's because this is 89 is a true age which I put it,
Yeah.
but for
Okay.
discussion
Maybe
purpose,
around
let's
70
assume
years. Yeah.
79.
Just
Yeah.
around 70. Yeah. Yeah. Again, that's fine. So I think it's the dynamicity is always there, because in the initial visits there will be very much tense and all, and again the tumor will have its own issues also, and most of them will respond at least initially to the treatment, so their general health improves also at least initially if you are able to give the correct treatment and the correct monitoring and all. Almost 70 to 80% they will get relief from their symptoms whatever they were there, and usually they bounce back. So these fluctuations we see from the baseline, and if they are going down, that is again is an indicator that we may not be able to continue treatment. So they have to bounce back. That is one of the
Right.
mandatory.
Dr. Prem, assuming the drop in frailty, you have done frailty in this patient at the age of 79, and you see frailty index very high. I counteract and say that this patient's reserve was good because patient does not have any comorbidities, no geriatric syndrome, blah, blah, blah. Patient has leukoplakia for almost 1 year or so, and now squamous cell carcinoma because of 4 months. Patient is not able to eat. As a result, patient's muscle, weight loss is there. Because of pain pressure, patient's quality of life is poor. She's dependent and she's frail. How do we differentiate just one external stressor? This particular graph tells me a lot, because if we address, assuming Dr. Arun has said, we give immunotherapy, patient responds very well, and suddenly you realize we made a mistake probably of putting frailty as very high. Dr. Prem.
Yeah, so I would say one of the very important things that you're showing here is the fact that there are three terminologies here. One is resilience, one is intrinsic capacity, and one is, of course, frailty. Now, resilience is obviously the way that a person will have the resolve to fight. Intrinsic capacity is a new concept which has come up, wherein we look at how the person is in 4 or 5 things. One is, of course, vision, one is mobility, then hearing, basically sensory and mobility. So it actually helps us in telling what, I mean, the concept of frailty has become important, but intrinsic capacity has become even more important now. Now, as far as the thing that you told me, now the thing is, we actually have a significant stressor in this particular person. For me, anything that affects nutrition in any age group is a problem. Anything that affects nutrition in an older adult is a huge problem, because if the oral lesion is the reason why the nutrition has actually affected, so then it becomes malnutrition begets frailty begets malnutrition. So it has actually become more of a vicious cycle in that. So in this case, if you tell me, I mean, as far as a perspective of the person is concerned, as a clinician, that we are doing that, removing that would actually improve. I'm just giving a, I mean, it's not necessary, it will, but removing that will actually help in improving the nutrition. Then I would obviously would want to see where the frailty is and would still want to go for treatment. And I would not go on the age at all. Of course, as we all know, in various forums, we have all discussed that the phenotypic and actual age is different. But I would definitely want to see this as a trigger, because there has been a trigger why the frailty is actually affected, especially in this particular person.
So I think Dr. Prem has brought out a very interesting and important point, and which I wanted also to stress, that I also realized later on also that frailty is very dynamic, and sometimes, at least I have 4 to 5 patients where I had written off them saying that, oh, I can never treat them, and they all bounced back. where we could give them some treatment for cancer. And I think this is very important, which we need to understand. This is like, akin to, we say performance status of 4 according to ECOG criteria, but somebody who has a spine metastasis is paraplegic will be PS4. But suddenly you do the surgery of the spine and the patient bounces back. So we have to remember that there can be a correctable external stressor which reduces or increases the frailty in patient. Dr. Priya ma'am, Dr. Arun has admitted this patient in IP for immunotherapy, stroke chemotherapy. What are the instruments which you routinely do to assess the frailty? Ma'am, we have only 6 minutes left now, so I would request that if you can answer fast so that we can cover more points.
Comprehensive geriatric assessment and the clinical frailty scale.
CGA and
So-
clinical frailty scale.
Frailty scale.
Right.
Yes.
Dr. Prem, very quick.
Yeah, I mean, CFS is very easy to do. I would want to, I mean, depending.
Only name the instrument, Dr. Prem.
Yeah, CFS. Then I would want to do a TUG, timed up and go
Okay.
test. But of course, it will be included in the CGA anyway. So it will be a
Geriatric
CGA and a CFS. Same.
Right. Dr. Arun, you have admitted patient for IO and you have referred to Dr. Priya and Dr. Prem and they have asked for CGA. Again, correct me, Dr. Priya and Dr. Prem. C stands for comprehensive, not screening. We are talking of G8 and visual analog scale 13 is a screening modality. But you both are saying that comprehensive. Dr. Arun, do we have the resources and the luxury to do a full comprehensive geriatric assessment in every patient you admit in IP, or you would like to start with screening like G8 or VES 13?
I think screening is always better because even when they come for follow-ups, we'll be going for that only.
We'll be going for that only.
Single measurements will be possible.
Right. Dr. Priya, if the patient's G8 and VES 13 is below the normal range, would you go for CGA in those patients or you would leave them alone?
In the IP setting also, if you can take the help of a geriatrician, we can do the comprehensive geriatric assessment actually. Than the screening.
I'm asking, I agree, ma'am. So CGA is ideal for everybody. But what I'm saying is if you have done the screening like G8 or VS13, if they are normal, would you recommend CGA in these patients?
Yes, because with the underlying malignancy, because definitely CGA will be better.
Okay. ESCO, ma'am, because you are a geriatrician, I would not ask you, but I would not counter your point. Prem, you would know that ESCO guidelines, they say that if the screening is normal and the patient's physical parameters are normal, you can skip CGA. Am I right? Or as Priya ma'am said, no, CGA should be ideal for everybody.
Yeah. ASCO says that I would still do the CGA, but
you would still do the CGA. So both the geriatricians in the panelists are saying that they would do the full CGA. My personal experience has been, last 3 to 4 years, especially during the COVID time, I have done many video screening of the frail patients, elderly patients, and somehow they have correlated. If the screening is okay, I have not required CGA. Although since I don't have the data of CGA, I cannot say, but the clinically did well and it was okay. Okay. Priya ma'am, all these studies of geriatric assessment, they are only predictive. As you can see here, associated with poor overall survival, associated with more side effects. They are only predictive. Does it help us, or it is just to say, okay, you are going to do bad, you are going to do well?
So I think it is more of a predictive, no, sir.
More of a predictive. Dr. Arun, have you seen clinically any patient where the geriatric assessment was done and then something was done about these patients and then again you felt that the patient did better?
I think basically our patients' problem is with the tumor symptoms. So once we start treatment, most of them improve, at least initially. And if we are able to quantify, then also that same thing will be reflected there also. That's what initially at least we see.
Okay, understood. Dr. Prem, patient comes to you, you find the patient to be frail. Ma'am said there are some corrective factors, B12, hypothyroidism, anemia, all those things. Apart from that, apart from the objective lab parameters, do you do any corrective measures if the patient is found to be frail, or you label them as frail, assuming they are not because of the tumor? Cancer is not an external stressor, and you find them to be frail. Because of the lack of time, we have 3 more minutes. This is what I came to know, that social status, functional mobility, autonomy, we can do something about these frail patients. Every aspect, you can do something about it. So do we do this routinely? Do you do this routinely in your practice?
Yeah. So that's where
Yes.
I think you should activate your multidisciplinary, your team members. So the physiotherapist, the dietitian. So as soon as frailty is detected, supplements is one thing, but initiating the multidisciplinary team, because especially ma'am had highlighted exercise. I think exercise and mobility is directly proportional to improving frailty. Immobility is the death knell for an older adult. So we need to obviously make sure, and the more the frailty, the more there's a chance of sarcopenia. So when muscle loss happens, again the vicious cycle starts. So I think definitely, these 4 parameters that you have actually highlighted are very, very important. And of course, this slide also, which you are showing, that all domains, if you intervene properly, there is a better chance of actually improvement.
Dr. Arun, Dr. Prem tells you that give me 1 month. Don't treat cancer for 1 month. I will make this patient fit and send it back to you. How many patients do you think are ready to wait for that time, or they will seek another oncologist?
I'm sure that an experienced person like Dr. Prem won't say that, because anyway, this malignancy has been endemic and rapidly progress. So I think that is not an issue at all. But anyway, the patients will have this doubt. They usually ask us whether the health is so weak, so should we wait for it to improve? That is a question which people or the relatives ask us. And our answer is always the same. Yes, it is because of the tumor that he or she is going down. So we cannot wait further. So I think that's a normal doubt for the general public.
So in this particular patient, assuming this patient had leukoplegia for more than a year and now has squamous cell for 2-3 months, patient is symptomatic only locally, and there is some 2-3 kg weight loss, and assuming all these things, assessment can improve her frailty index, and if you have to wait for 1 month, is it practical oncology wise? Forget about patient, is it practically possible that you say, okay, let's wait, let the patient be fitter, I can give a better dose of IO or chemotherapy?
Not possible, I feel, because it may not improve, because what you're alluding to is like a slow-growing tumor where we may have time, isn't it? So sometimes people do that. They go for some alternative treatments, and invariably what we have seen is that they become worse when they come back. So improving the health and then waiting for treatment may not be feasible in itself.
So I would want to be
So we have good
pragmatic.
news.
I would try to
Yes.
improve the help and give treatment together, because ultimately that would be the
Yes.
best.
Yeah.
way to go.
Side by side, we can do that. Side by side, all
Side
these
by
things can
side.
happen.
So till 2020, we didn't have any major trials. And in this slides, I have shown that there are 5 trials after 2020, which have shown at least the side effect profile has reduced if you do a geriatric assessment based treatment of cancer, whether it is post-surgical complication, whether it is falls, whether it is hospitalization. I may say I was very skeptical of overall survival in CGA-based treatment. But when you see the patient is less hospitalized, patient has less falls, patient has less side effects, I think quality of life, in spite of the same survival, I would go for comprehensive assessment any day as compared to not doing it. That is something we have. So we have some improvement. Dr. Arun, do you use CARG or crash score frequently in your practice? Last 2 minutes I will take and then I'll wind up.
It's always better to have a score at the beginning, so that we are able to talk to the relatives. That's the importance, I feel. And we know it's a high risk patient anyway. But if you give a score, it makes them understand in a better way. So we are giving some score, so this much chances are there. In that way, these things help us. But invariably, the treatment decision may not be best.
Dr. Prem, how much reproducible CARG and crash score in your day-to-day life? Say CARG score is 15. You feel that it is correlating with this thing? Why I'm saying is that I have again put one table here. If you see, there is a mixed thing. 259 patients, the second trial, if you see on the table,
Yeah, I
259
did not.
patients CAR did not predict. And this was 2021. In the same year, same number of patients, same age, CAR predicted.
Yeah, so I would still say that CARG only gives you a prediction. It is not the know all and end all. You need to look at that, but at the same time, look at the overall picture of that particular person along with the geriatric assessment and decide. Because I feel ultimately going purely on CARG will not be the right way to go. It's only an indicator. It only helps you to say, no, there will be toxicity. It's not saying there will be for sure.
I think this is again a second important point which Dr. Prem has said. CARG is basically gives you an idea. It does not mean that you have to give chemotherapy or don't have to give chemotherapy based on CARG or CRASH. Both are good tools for you to understand and counsel the patient. So this patient screening GA was absolutely okay. We started with immunotherapy, patient tolerated extremely well. We started with injection methotrexate 50 mg once weekly and patient just collapsed and couldn't tolerate. So I would not go into the details where we went wrong, but somewhere definitely comprehensive geriatric assessment, whether it would have helped, whether CARG would have helped, we don't know. But each individual patient is different. And as WHO says, united by unique. That is the new mantra. Each individual patient is different and you have to unite them based on our experience. So this particular patient finally is a compromise. Nivolumab 40 mg, very low dose, once in 3 weeks. Methotrexate 50 mg once in 3 weeks. No protocol gives this type, but this is what we have given in this 89-year-old patient. MRI done twice, shows stable disease. With that, I hand over to Dr. Prem. Thank you so much for giving me this opportunity.
Thank you, sir. So I think this is an ideal case in which we have seen that flexibility in older people is very important. And I think its regimens might be there, but ultimately we had to take a conscious decision of creating our own regimen, which actually helped the older adult in this case. Purvish, sir, any comments before we close? Sir?
Dr. Parikh, sir.
Sir is not logged in with audio, so it will not be able to hear us.
Okay, then. Okay. I mean, I would want to thank first of all our presenter, Dr. Priya. Thanks for giving us a very good insight into frailty, and our excellent moderation by Dr. Amish, and of course our panelist along with Dr. Priya, that is Dr. Arun. So look forward to you all joining us next month. Thank you. Thanks a lot, and have a very good evening. Thank you.
So Dr. Prem, I wanted to congratulate you for doing this consistent and persistent endeavor. And especially, as it can be seen from the number of attendees, that I think your program is getting useful to many people, and you should continue that. And again, congratulations to you, Dr. Prem.
Thank you, sir. Thanks for that encouragement, and thanks for all the great insights which we always get when you present cases, because I think it's a very rich sort of. Sir is here. Purvish, sir, any final comments? No? Okay.
Sir has muted himself again. No. Okay.
Okay, sir. So
Thank you.
I'm unmuted now.
yeah, sir. So any final comments before we close?
I was flabbergasted. Yeah. Priya has done such a fantastic job of discussing frailty. And when Amish was asking questions to you, Prem, you were looking up only, as if you are getting direct connection from the God here. I have to ask you, what is your special number that you connect up here? But I think seriously, so many fundamental understanding of what is the assessment of frailty. It can't be vague. It has to be specific. That particular assessment of frailty, I got a lot of insight into it. So Arun's workshop, where I was able to demonstrate how old people are walking in a frail stand up and go thing. But Priya has really done a great job here. No wonder, Prem, you are gaga and always praise your teacher here. Now I understand why you keep doing that. Thank you very much. Thank you.
Thank you, sir.
Thank you.
Thank you again. Thank you all. Good night. Bye-bye.
Good night.